If we look at the distal end of the vagina, we'll find two bulbospongiosis muscles that will extend on either side of the entrance, but there will also be two vestibular bulbs, and these have the same origin as the corpus spongiosum of the penis, but the corpus spongiosum is what contains the urethra. In this case, the vestibular bulbs will open out on either side of it, so it has very similar embryonic origins as the corpus spongiosum of the penis, and the clitoris also has its own corpora cavernosa that are analogous to the ones in the penis. So we have, if we look deeper into the vagina, we'll find a non-keratinized stratified squamous epithelium, and it's going to have these folds in it that we've seen called rugae, again, to aid in the distension when there is going to be childbirth. It also changes with the ovarian cycle, so that if one examined the epithelium of the vagina, they could tell pretty much in the cycle where the person was. So underneath the epithelium, we have the lamina propria, which has a lot of elastic fibers in it. It's going to contain blood vessels, nerves, and lymph nodes, just like we find in lamina propria of other organs. So the vaginal mucosa, this is going to have an elastic muscularis layer with smooth muscle fibers. These are going to be arranged in circular and longitudinal bundles and be continuous with the myometrium. So here it is. Here we have the vagina. Here's the vaginal wall with the rugae. Here we have the inner and outer layers of muscles here, and they'll be continuous with the myometrium, and they will not have that extra sort of oblique, multi-interlaced, it's not really oblique layer, but it's got crisscrossing muscles. We will not have that in the vagina like we had in the uterus. And this is this is going to be the cervix of the uterus and the externalis. And this will be the vestibule. Here we'll have the labia minor. Outside of that, we'll have the labia majora. And then we have several glands that will secrete into the vestibule. So here's a picture of the stratified squamous epithelium. Here's our lamina propria, and you'll see lots of blood vessels within it. And then we're going to have our smooth muscle out here. All right, so within the vagina, there are some bacteria, and this will create a slightly acidic environment, which may restrict the growth of some pathogens. And once again, you could probably take a sample of the epithelial cells at the surface of the vagina to estimate at which stage of the ovarian and uterine cycles the person is in. And if someone's trying to conceive, that might help them determine where they are in the ovulation cycle and when the best time for coitus is. Once again, for trying to conceive a child, the best time is about 3 days before up until ovulation. All right, the vulva is the external genitalia. This is also known as the pudendum, which is a rather unfortunate Latin term meaning the shameful part of something. And while the pudenda gets its name from, well, the Latin term, and the pudendal nerve also gets its name from this region, which is the same in both males and females, typically the pudendum has been typically used to refer to female genitalia and to a lesser extent to the male genitalia. But it's rather too bad that they had to use a term that means shameful, but that's what it means. All right, the vestibule is the space that surrounds the exit of the vagina. So we have a space, we have two folds, the labia minora, which is the inner fold, and the labia majora, which is going to be outside of it. So the vestibule is bounded by the labia minora. And this has that glabrous skin or hairless skin. And the urethra will also open in the vestibule, and in most females it's anterior to the vaginal entrance. In some females it might actually open into the vaginal entrance, but in most it's anterior to it. And in some cases you can have sort of a similar but opposite situation in males, and they might be born where the urethra, which is supposed to go through the penis, might be actually behind it. And this is an issue called hypospadia, which has to be surgically corrected. But in typical females, the urethra will open anterior to the vaginal entrance. All right, we've got some periurethral glands that are going to be discharging into the urethra near the external opening. These are also called Skene's glands. Then the clitoris is, the book calls it a small protuberance in the vestibule. Actually, it's quite a bit larger than previously estimated. And it really wasn't until the late 2009-10 that they actually made a real comprehensive 3D model of it and know what it looks like. And it has the same embryonic structures of the penis. It even has corpora cavernosa, and it's going to extend in front of the labia minora, and we have extensions of the labia minora called the prepuce or the hood, and this is basically the analog to the foreskin in the male. All right, so we've got some vestibular glands, greater and lesser vestibular glands, and these are going to secrete onto the exposed surface of the vestibule and into the vestibule near the vaginal entrance. And then we've got this area called the Mons pubis, which is going to be continuous with the labia majora, and the labia majora is the outer covering of the vulva, and it's going to protect what's inside. It has some adipose tissue in it, and it also has hair as well, as does the Mons pubis, and that's going to cover the pubic symphysis. So the Mons pubis is the part in the front, and the labia majora is the part going on either side of the urethral entrance and the vaginal entrance. And so here there are going to be some sebaceous glands and apocrine sweat glands as well, and they will secrete into the surface, the inner surface of the labia majora. All right, so this is what it looks like. This is the prepuce. This is the glands of the clitoris, which is about all of the clitoris you can actually see. We have the labia minora here, and then we have the labia majora here, and the Mons pubis. And then this is the vestibular bulb, which is embryologically equivalent to the corpus spongiosum in the male. Here's the greater vestibular gland. You can't see the others. And then, of course, posterior to that is the anus. Now that we've seen the female reproductive system, we can look a little bit at the mammary glands, which their function is to produce milk. And the interesting thing about the mammary glands is they will never fully develop unless you get pregnant and produce milk. So it's probably, instead of going through a bunch of slides, much easier just to look at a picture of it. So this is a typical mammary gland, and this breast here is going to consist of a lot of things. For example, there's a pectoral fat pad here, which gives it its shape. And then we have lobes, and the lobes are separated by partitions, and we have some suspensory ligaments here that are going to hold it to the chest wall here. And each lobe has lobules in it. And we're going to have these lobules full of tubuloalveolar glands that when the person becomes pregnant, they will start producing milk. And then later during pregnancy, they will release that milk or lactate, and so that the baby can feed. Now, each of these lobules has a duct, and these ducts are going to run into this lactiferous duct here. And the lactiferous ducts will collect up all the milk from the little lobules in a lobe, and that lactiferous duct will then empty into a lactiferous sinus. And about 15 to 20 of these will empty into the nipple. And the nipple itself is covered by an area, or surrounded, I should say, by an area called the areola, which is that darkened skin around the nipple. And it's interesting to note that both males and females have nipples and lactiferous ducts, but in males, you don't see those become functional. Males will not get pregnant and lactate, obviously. But males do have lactiferous ducts, and they do have nipples. And if they have a high amount of estrogen or hormone, they will develop the pectoral fat pad as well, and they'll develop the same breast structure that a female will. All right, so if we look at the inside of this, here is a mammary gland that is not functioning. So we've got some secretory alveoli, a lactiferous duct, and some connective tissue, but nothing's happening in this mammary gland. If we look at a gland that is active, we'll see that the secretory alveoli are now full of milk, and then this lactiferous duct has milk in it. All right, so the interesting thing about this is in order to eject milk, there is a reflex, the milk letdown reflex, that happens when the baby suckles, the actual physical contact with the nipple. And there's also a release of oxytocin. And oxytocin, one of its jobs is to cause lactation, or actually cause the release of milk to the infant. Now we're going to have another hormone that becomes important in pregnancy called prolactin, and that's going to support the development of milk in the mammary glands, but it's going to be oxytocin that causes the release of milk when the baby starts to suckle. Right, now we can talk about the hormonal influence of the female, which, as we have seen, is quite different from in the male. Whereas the male, the hormone levels stay relatively even and they fluctuate around a set point. In females, it's quite different, as we see, because the hormones are what's going to coordinate the cycles, the uterine and ovarian cycles. So we've got the pituitary gland that's going to secrete FSH and LH, and this is going to be done at different times, and this is going to cause a little bit different way the gonads are going to respond. And of course, the uterus, which is basically where gestation will occur, will have to be in sync with the ovarian cycle because the uterine cycle has to be prepared to accept the oocyte if it's fertilized. And so we're going to have circulating hormones that are going to be, first of all, the ones from the anterior pituitary are going to affect what the ovaries are doing, and then the hormones from the ovaries are going to affect what the uterus is doing. All right, so as we know, we have gonadotropin-releasing hormone from the hypothalamus. We will see that the gonadotropin-releasing hormone is quite different in how it is released than for men, because we're going to have both the frequency of gonadotropin-releasing hormone release and the amount will change throughout the course of the ovarian cycle. So we're going to see a lot of this is going to be dependent on feedback mechanisms, because estrogens will increase the pulse frequency and progestins will decrease it. So these are the signals from the gonads as to where they are in the cycle. So that's going to then tell the hypothalamus when to change the GnRH release. So for example, estrogens that will be produced predominantly in the follicular phase of the ovarian cycle will increase the release of gonadotropin-releasing hormone, the pulse rate, that is how often it's released. And in the male, we saw it was about 60, a release every 60 minutes or so. And progestins will actually decrease that pulse frequency of release of the gonadotropin-releasing hormone. And progestins, as we saw, are going to be released after ovulation when the corpus luteum has formed and is converting that cholesterol into progesterone. All right, so we've got our endocrine cells within the anterior lobe of the pituitary, and of course these group are going to respond differentially to the differential gonadotropin-releasing hormone pulse frequencies. And of course our endocrine cells in the anterior pituitary are going to be releasing follicle-stimulating hormone and LH. And so some of these follicle-stimulating hormones will be sensitive to release of gonadotropin-releasing hormone at different frequencies than that of the luteinizing hormone. So we're going to start the follicular phase with follicle stimulation hormone, and that's going to cause some of the primordial follicles to develop into primary follicles. And as the follicle enlarges, they're going to be producing androstenedione. It's actually the thecal cells that are going to be producing the androstenediones, and then the granulosa cells will be converting androstenedione and testosterone into our estrogens. And then, so androstenedione is one of our precursors. It's a steroid hormone. It's one of the androgens. And that's going to be an intermediate, as we've seen, in the synthesis of estrogens and androgens. So it's also going to be a precursor into testosterone. That will be absorbed by the granulosa cells and converted into estrogens using our aromatase enzyme. And we're also going to have interstitial cells in the ovarian stroma that are going to secrete estrogens. And the estrogens are, again, going to be bound to albumins. And some will be carried by a gonadal steroid binding globulin. And we're going to see three types of estrogens: estradiol, estrone, and estriol. I'm not going to get into a lot of detail on these, but basically estradiol is the most abundant. This is going to have the most pronounced effect on the target tissues, and it's going to be the dominant estrogen prior to ovulation. So as we see, estrogen synthesis is dependent upon testosterone, and as I said, androstenedione is basically a precursor to testosterone, and it will also be a precursor to some of these other estrogens, but estradiol is the most dominant form, and estrogen will be converted to estrogen from testosterone using our enzyme aromatase that we talked about before. And as we said, estrone and estriol are converted directly from androstenedione. All right, so we have 5 functions of estrogen. one of which is to stimulate bone and muscle growth, so very similar to what testosterone does in males. It also stimulates secondary sex characteristics, so for example, distribution of adipose tissue. So we know that females will carry fat in different locations from males, and they also will have an extra amount of adipose in the breasts, in that pectoral fat pad, and that is going to be stimulated by estrogens. We also will see that there's going to be central nervous system effects because the hypothalamus obviously is going to be sensitive to these estrogens. And estrogens will not only increase sexual drive, but also it's going to program the hypothalamus as to when it's going to be releasing gonadotropin releasing hormone. So the hypothalamus is looking for these feedback signals from these other hormones in circulation to know when to change the pulsing activity of gonadotropin releasing hormone release. All right, obviously we've got to maintain the functional accessory reproductive glands and as well as maintaining the organs itself. And of course, it's also the initiate the repair of the endometrium, because once estrogen is produced by the follicles in the ovary, then of course that's going to signal the start of the proliferative phase in the uterus. All right, so then we've got the follicular phase of the ovarian cycle. The estrogen levels are low at first, so our gonadotropin releasing pulse frequency is going to be about 16 to 24 pulses per day, or one about every 60 to 90 minutes. But as the tertiary follicles form, the concentration of estrogens is going to rise. And now we're going to have an increase in pulse frequency to about 36 a day, or one every 30 to 60 minutes. So now we can see how the amount of gonadotropin releasing hormone is going to change as the concentrations of these hormones are rising, especially estrogen here is rising. Now, in the follicular phase, we're going to have the switchover occur when the estrogen levels exceed the threshold value for about 36 hours, and this is going to cause a massive release in luteinizing hormone from the anterior lobe of the pituitary gland. And then that surge is going to cause the completion of meiosis 1 by the primary oocyte and the rupture of the follicular wall, in which the tertiary follicle will spit out what is now a secondary oocyte. So the completion of meiosis by the primary oocyte converts it into the secondary oocyte in that tertiary follicle, and that is what will be ejected into the pelvic cavity. And so the actual ovulation occurs right about 9 hours after the peak in luteinizing hormone. So this, of course, will trigger the promotion of progesterone secretion by the corpus luteum, which is now going to form from that tertiary follicle that is involuted after it has expelled the oocyte. Now, at this point, the frequency of gonadotropin releasing hormone is going to stimulate luteinizing hormone more than FSH. So because of the changeover, then once estrogen has reached its absolute threshold, that's what's going to cause the changeover in frequency of the gonadotropin releasing hormone, and that's what's going to cause the release of luteinizing hormone. So once the luteinizing hormone has been released, the reason it gets its name luteinizing hormone is that it sets up the ovarian cycle to move into the luteal phase. So the progesterone levels will remain high while that corpus luteum is producing progesterones for about a week or 10 days after ovulation. And then a little bit later, the corpus luteum will start to degenerate and progesterone levels will drop. During this time, during the second half of the ovarian phase, during the luteal phase, we will still have some production of estrogen, but not nearly as high as we did in the follicular phase. But as the corpus luteum starts to degenerate, progesterone levels will drop, estrogen levels will drop, the gonadotropin releasing hormone pulse frequency will also decrease. And once the progesterone and estrogen levels drop, that's going to signal the uterus to move into the menses phase. So that's when the whole functional layer of the endometrium will start to slough off. And so that's when we enter the menses phase of the cycle, of the uterine cycle. And at that point, once our gonadotropin releasing hormone frequency decrease back to where when we started, that's going to start the secretion of follicle stimulating hormone again, and that's going to begin the ovarian cycle again. So remember, it's at the very beginning of the follicular phase in the ovarian cycle that menses occurs. And menses occurs because of that precipitous drop in progesterones and estrogens. And that's when we're going to start the cycle again of gonadotropin releasing hormone returning to its previous levels. And what will happen then is, in the absence of estrogen and progesterone, the menses will occur. That is the sloughing off of that endometrium, that functional layer of the endometrium, and FSH will start to be secreted again by the hypothalamus. And that's going to cause the follicle to start maturing, one of those follicles to start maturing, and then, of course, it's going to start secreting estrogen again. And then, when estrogen levels reach a sufficient level, then menses will stop, and we'll start back to the proliferative phase of the uterus again. And that's when we restore the functional layer of the endometrium, and that proliferation phase will continue, of course, until we have our LH, which is going to cause the ovulation and therefore the shift into the luteal phase of the ovarian cycle. Corpus luteum will create the progesterone. The progesterone will then cause the uterine cycle to shift into the secretory phase. And this is where we see the enlargement of those endometrial glands, and we see a lot of secretory action going on. And so that is going to be the second half of the ovarian and uterine cycles coordinated together. And so this cycle just continues. Now, of course, the question is, and has been for many, many years, way before we had any kind of hormone therapies or birth control or anything like that, how did people know when they were likely to get pregnant? Well, one of the ways that people figured it out was their body temperature will change. So actually, your body temperature is lower before ovulation. So during the follicular and proliferative phase, body temperature is a little bit lower than they are afterwards. So once you have the surge in LH and you have ovulation, then the body temperature will start to increase. And if you take your temperature every day, if someone is trying to get pregnant, what she would do is she would try to figure out the length of the cycle and try to figure out the day on which she ovulated. So she would take her body temperature during every morning and see what it was and see the day when it increased. And she would figure that would be the day that ovulation occurred, and then she would start to count the days at the end of the cycle and anticipate when ovulation would occur and try to time coitus to be within those few days before ovulation.